Hey everyone, if you're a coding student, you know there are some areas in CPT that can really make you scratch your head. Well, today we're jumping right into one of them, intra-abdominal excisions. We're going to break down all the rules so you can go from feeling confused to feeling totally confident. Let's get right into it.
So here's the big question, right? A surgeon goes in, removes a bunch of tumors from the abdomen. You get the operative report and it looks complicated. How in the world do you translate that complex surgery into the right CPT codes? It can feel a little overwhelming, for sure. But don't you worry, we're going to give you a really clear framework to follow. And here's our game plan for this explainer. We're going to start with the big picture, get our bearings, and then walk through each key part one step at a time. We'll start with sclerotherapy, get into the core excision codes, and really dig into the super important measurement rules. Then we'll wrap it all up with a checklist to make sure it all sticks. Sound good?
Okay, so let's zoom in on our specific toolkit for today, CPT codes 49180 through 4925. This specific range covers a whole lot, from fairly simple injections to some really complex tumor removals. Now, the key thing to remember is that these codes are for growths that aren't part of a larger primary organ resection. That distinction, it's going to be crucial as we go on. So, to build a really solid foundation, let's start with the most straightforward code in this whole series, 49185 for sclerotherapy. Seriously, if you can lock down the logic here, it's going to make understanding the more complex excision codes so much easier down the line.
So what exactly is sclerotherapy? Well, imagine a surgeon needs to treat a fluid collection, something like a cyst. Instead of doing a big open surgery, they can go percutaneously, which is just a fancy way of saying right through the skin, and inject a substance that helps collapse and close up that collection. That's the procedure that code 49185 describes. Now here's some good news. Code 49185 is what we call an all-inclusive or bundled code. This means you don't have to worry about reporting all these different parts separately. The imaging guidance, the injections themselves, the supervision, it's all wrapped up nice and neat into this one single code, which definitely makes your job a little easier. Okay, this slide right here, this clears up a super common point of confusion for students. It's not really about how many lesions are treated, it's all about the number of access points. So, if the surgeon uses a separate catheter for each fluid collection, you report 49185 for each one. But if they use the same catheter to get to multiple lesions, you only report 49185 once. The catheter is the key, remember that. And here's a little pro tip for you. While 49185 bundles the treatment itself, the work of actually getting access to that fluid collection in the first place and draining it, that might be reportable with a totally separate code. So always check that operative report to see if an access or drainage procedure was done that you can also code for.
All right, we've got sclerotherapy handled. Now let's move into the real heart of this code series, the open excision and destruction codes. This is where things get a bit more complex, because now we're talking about open surgeries, where the surgeon is getting in there and physically cutting out or destroying growths.
These codes, 49186 through 49190, are your go-to for these open procedures. When you're reading an op report, you'll probably see terms like cytoreduction or debulking. Don't let those throw you off. They're just clinical terms for reducing the size or number of tumors. All of those different methods are captured by this specific set of codes. Okay, everybody lean in for this one. I'm serious. If you remember only one thing from this entire explainer, make it this section right here. The selection of the correct code from 49186 to 49190 depends entirely on one single thing, measurement. Getting this right is absolutely everything.
Let's walk through this like a checklist. First, the measurement has to be taken in situ. That means while the tumor is still inside the body, before it's cut out. Second, you take the longest dimension of each individual tumor and you add them all together to get your total sum. Third, and this is so important, you only measure the tumor itself. Which leads to our fourth point, you have to exclude any healthy margins or surrounding tissue that might be removed along with it. The measurement is for the lesion, period.
And this brings us to the most important rule in all of coding, right? If the physician does not document the size of those tumors in the operative report, you cannot guess, you can't estimate, you cannot code for it. This is a non-negotiable rule. No documentation, no code. It is that simple.
Okay, now let's tackle a situation that trips up so many new coders. How do these excision codes play with other major procedures? What happens when a surgeon is removing tumors during a big organ resection? Let's get these rules crystal clear.
This is such a classic scenario.
Picture this. A surgeon is performing a colectomy, removing part of the colon, and they happen to find some tumor implants nearby. So do you code for that tumor removal separately? Well, the answer is, it all depends on exactly where that tumor is.
And this table just lays it out perfectly. If those tumors are growing right on the piece of the colon that's being removed, then taking them out is just considered part of the colectomy. You only code the colectomy. But if the surgeon removes the colon and then moves to a totally separate area, like the mesentery, to cut out other tumor implants, then yes, you code for both procedures. The key phrase to remember is separate and distinct.
Now, you're going to want to pay close attention here because there is a very specific exception you have to know for gynecologic or GYN cancers. You only use our codes, the 49186 to 49190 series, for a recurrent GYN malignancy, and only if no lymph nodes are removed. For pretty much all other GYN tumor resections, you're going to be looking in a completely different section, the 589XX code series. It's just one of those very specific rules you have to memorize.
And one last quick thing to keep off your radar for this code set. If the op report says the surgeon is just cutting away scar tissue, which are called adhesions, around the intestines, that's a different procedure entirely. For that, you're always going to use code 44005, not anything from the series we've been talking about today.
Wow, okay, we have covered a ton of ground. So let's lock in everything we've learned with a final check of the most important rules. Think of this as your personal cheat sheet for getting these codes right every single time.
So here it is, all in a nutshell. For sclerotherapy, it's all about the catheter access. For those open excisions, it's all about the sum of the maximum lengths, measured in situ without the margins. Remember, don't code the tumor removal separately if it's just part of the main organ resection. And always, always keep those very specific exceptions for GYN procedures and lysis of adhesions in the back of your mind.
So I'll leave you with this final thought. As you keep going on your journey as a coder, you're going to find that just memorizing the rules is only the first step. True mastery, true confidence, comes from understanding the context, knowing the exceptions, and knowing precisely when a rule doesn't apply. That is the real art and science of being a great medical coder. Thanks so much for joining me.